This morning we will be presenting some new research related to autism prevalence among Utah children. And we have two of the co-authors with us today, Dr. Debbie Bilder and Dr. Amanda Bakian, along with, let's see if he's still with us. Oh, he is, Colin Kingsbury from the Utah Department of Health. He's with us as well, and they will be spending a few minutes presenting the findings from the research, and then we will take questions. So if you have questions, please put them in the chat, and we will be asking questions towards the end. But I will turn the time over to Dr. Bakian first, and then Dr. Bilder, and then we will, like I said, ask questions towards the end. So please put them in the chat at any time, and we'll ask the questions towards the end. So thank you. We also are putting all of the names and titles in the chat, and there is a link to the press release in the chat as well for you. So Dr. Bakian, take it away.
All right, good morning. I'm Amanda Bakian, Associate Professor of Psychiatry at the University of Utah Huntsman Mental Health Institute and Principal Investigator of the Utah Autism and Developmental Disabilities Monitoring Network Project. Since 2000, the Centers for Disease Control and Prevention have been tracking the prevalence and characteristics of 8-year-old children with autism spectrum disorder through the Autism and Developmental Disabilities Monitoring Network, called the ADAM network for short. Tracking in 4-year-olds was added to the ADAM network in 2010. Utah last participated in the ADAM network in study year 2012. So it's been 6 years since our last report on autism prevalence in Utah using CDC methodology. Autism continues to affect many children and families in Utah. Services and support for these children are critical in early childhood and as they grow into adolescence and adulthood. Utah's participation in the ADAM project is critical for providing valuable information to determine service needs, provide resources for families affected by autism, and improve early detection and community outreach. The Utah Autism Project is supported by the Utah Department of Health. But this work would also not be possible without the collaboration of Utah's major health providers, including Intermountain Healthcare and the University of Utah, as well as from the Utah State Board of Education and the individual school districts in Salt Lake, Davis, and Tooele counties. So this morning, I'd first like to walk you through some of Utah ADAM's primary findings for study year 2018, and then put them in the context of broader ADAM network findings. Additional detail on network-wide findings can be found in the 4- and 8-year-old scientific reports that are published today in the Morbidity and Mortality Weekly Report or in the ADAM Network's 2021 Community Report. When I'm done, Dr. Bilder will then speak to some interpretation of our major findings. So Mitch, if we could pull up the graph, the state page, that would be great. So we'll just use this state page to help guide our conversation this morning. First, I'd like to say that the work that the Utah ADAM Project did was done in a 3-county surveillance area. So Davis, Tooele, and Salt Lake counties. So for both the 4- and 8-year-old Utah ADAM projects, the underlying population of children were about a little bit over 25,000 children in this 3-county surveillance area. So for both the 8-year-old project, 25,000 children, and the 4-year-old project, 25,000 children. Among 8-year-old children, the prevalence of autism in 2018, was found to be about 1 in 46 children. So this turn is about 2.2% of 8-year-old children in this 3-county surveillance area. To put that in the context of the broader ADAM network, the overall prevalence across 11 participating ADAM network sites was 2.3%, or 1 in 44 8-year-old children. And the prevalence of autism among 8-year-old children in Utah was not different than what was found across the entire ADAM network site across all 11 participating sites. Okay. Other characteristics that we looked at in terms of autism among 8-year-olds included the median age at first identification, So among our 8-year-old children, we found 54 months of age to be the median age of identification. This does not differ than prior years that we participated in the ADAM network, including 2012. We also looked at the proportion of children with autism who had co-occurring intellectual disability. Among 8-year-old children, 27% of children with autism had co-occurring intellectual disability. This is a little bit lower than across the entire ADAM network, but consistent with prior estimates in Utah, so consistent with study year 2012. In terms of focusing a little bit on what we found among 4-year-old children in Utah, or in our 3-county surveillance area, we found that the prevalence of autism is 1 in 109 4-year-old children, or about 0.9% of 4-year-old children. The prevalence of co-occurring intellectual disability was higher in 4-year-old and 8-year-old children in our 3-county surveillance area. So 59% of our 4-year-old children with autism had co-occurring intellectual disability. This indicates that among our younger children, we are first identifying those that, or we're more likely to identify those with co-occurring intellectual disability. Then a little bit additional information about study year 2018. The male to female ratio was 3.6 males to every female. And that is consistent with prior study years in Utah, as well as the entire ADAM network in this study year. And then one last piece of data to report is when we consider the likelihood of being identified by age 4 in the 2014 birth cohort, so those were children participating in the 4-year-old Utah ADAM study, versus the 2010 birth cohort, which are the children participating in the 8-year-old ADAM study, we see that children in both birth cohorts were just as likely to be identified by age 4. So no difference in the likelihood of getting identified by age 4. So those are some of our major findings to highlight from in the Utah ADAM project. And now Dr. Bilder will take some time to talk about the interpretation of these findings and add a little bit more detail to our findings.
Thanks, Dr. Bakian. I am also quite appreciative of all our stakeholders and data sources in our community to make this possible so that we could participate in this nationwide process of identifying the prevalence of autism spectrum disorder. As far as putting into context the findings that Dr. Bakian just described, the higher rate that we measured among 8-year-olds is likely, at least in part, related to the increased ability of children to access diagnostic services as well as treatment services. The reason why I'm suggesting this is because we also saw quite an interesting change among the socioeconomic status of the children who are identified with autism. Children who are identified with autism spectrum disorders during this study year had the highest prevalence among that group of children who were in the lowest socioeconomic tercile versus the highest socioeconomic tercile, which is what had the highest prevalence of autism in the past. We feel this really demonstrates the substantial impact that legislation has had in Utah over the last decade in making remarkable differences in the access children, particularly those of the middle and lower terciles of household income, in being able to access diagnostic and treatment services. These are among children who may otherwise have had no opportunity whatsoever to access diagnosis and treatment services. What we did find, though, is that we still have a discrepancy in regards to rate of autism spectrum disorder among our Latino population, with that population of children 8 years of age having a lower measured rate of autism spectrum disorder than other children in our community. Because there's no understood reason to think that the rate of autism will affect children of different ethnic or racial backgrounds differently, we feel this really reflects our need to step up our efforts even further on helping those children and those families access diagnostic and treatment services as well when concerns arise. So I would like to open this up to further questions.
Well, thanks, Dr. Builder and Dr. Bakian. I want to take a second and ask the state, Colin, if there is any additional comments that he wants to make in support, or if there's anything that they want to contribute to the conversation this morning.
Yeah, so what I think Dr. Baking and Dr. Builder pointed out is an increased access to services, which is such a wonderful opportunity for families of all socioeconomic statuses to get access to the diagnostic services they need. And looking at the 4-year-old prevalence rate, it's a little low, but the state has worked tirelessly with all of our partners, including the University of Utah, the University Developmental Assessment Clinics, Intermountain Healthcare, Valley Behavioral Health, and many, many more to try and get kids screened earlier and into those diagnostic services as soon as possible. So we're hoping, since we've launched these initiatives over the last 2 years, we'll see a much better, more accurate prevalence rate for 4-year-olds in the near future. And that'll really tell us if those initiatives are working. So I just want to thank all of our community partners for all the wonderful work that they've been doing in trying to solve some of the problems that are highlighted by this data.
Thank you, Colin. Our first question is from Paul Nilsson. Paul asks, what did we believe was the rate of autism in 8-year-olds, and what was the actual rate you found in the last study?
So we didn't quite, well, so we had a benchmark from study year 2012, where our estimate was 1 in 58 8-year-old children. So that was 1.7% of 8-year-old children surveyed in 2012, which was the same 3-county surveillance area. So that was our starting place. We weren't quite sure what to expect. We had a lag of 6 years. But seeing how there had been change across the overall ADAM network, where there had been a little bit of a stepwise increase every 2 years. This is a study that's done every 2 years. We hypothesize that we may see a similar increase within Utah, within our 3-county surveillance area. Of course, another thing to say is the sites that participate in the ADAM network change every 4 years. So this incremental increase in autism, we don't exactly know the source of that increase, given the changes in the participating sites and other changes that happen. So our statistically significant increase in the prevalence of autism between 2012 and 2018 didn't come to a total surprise to us, given what we had observed elsewhere and in the past in Utah.
Suzanne, is it okay if I clarify just some of the numbers that I asked about?
Yeah, go ahead.
Okay, so we thought the benchmark was that we believed it was 1 in 58 8-year-olds had autism, and now we found it was it 1 in 48 did we see?
So for us in Utah, it's 1 in 46 now, or 2.2% of the 8-year-old population in our 3-county surveillance area. So when I say benchmark, we've had a lot of changes in Utah that affect what the prevalence of autism might be over time. So when I say that was our starting point, because our benchmark, because that's the last time we used CDC methodology to estimate the prevalence of autism. And it's not, so because of the changes that we've seen that include increased community awareness of autism, increased access to evaluation and diagnostic services for autism, it was for those reasons that we actually hypothesized that we were likely to see an increase in autism prevalence among 8-year-olds between 2012 and 2018.
Copy that. Thanks for letting me clarify that.
Oh, sure. Thanks for the question.
Okay, the next question that we have is about whether in the future we'll be looking at more age groups or a larger age group setting, and perhaps beyond 8, and why 4 to 8-year-olds currently, but what the future could look like with looking at other age groups.
Yeah, so historically, when the CDC first established the ADAM network in the year 2000, the idea that it was that we would see peak autism prevalence at age 8, that there would be sufficient time to allow a child with autism to be identified. So that is why age 8 has historically been the focus of the ADAM network. As I mentioned earlier, in 2010, 4-year-old the work in the ADAM network was brought in to include 4-year-olds. And the reason that was done was to get a more detailed sense of our early identification, because there's well understood that the earlier a child is identified with autism and the earlier they access services related to autism, the better the outcomes related to autism are for a child. So there is strong interest in trying to understand if children are being identified earlier. And of course, we recognize that children with autism grow up to be adolescents and adults with autism, and there has been in the past few years a shifting interest in understanding autism among adolescents and adults. So another piece that the ADAM network has recently incorporated is doing some follow-up work in prior birth cohorts at age 16. So part of the study year 2018 efforts were to look at the 8-year-olds in study year 2010, so at age 16 in 2018. Now that is work that will be published and we will report on down the road in the next few months. We are working on reports that will be disseminated in peer-reviewed journals for that work, but we do have that piece. So yes, the CDC is very interested in looking at autism at other age groups, and we are participating in that work as well.
In addition, we received supplemental funding from the CDC about a year ago to extend our understanding of autism across the state and across a much broader age range. Up to 24, 25?
24,
20,
age 3 to 24.
Age 3 to 24 years of age. And I feel this is absolutely critical in understanding what opportunities we need to create for these folks, what challenges they may be facing, and how they're currently getting their service needs, and what they could see potentially in the future once we understand better what that population of young adults, transition age adults look like who have autism spectrum disorder in our state.
Thank you both. Another question that we received is, typically Utah has ranked higher than most other states in rates of autism. Has that trend continued, and why is that?
So yes, historically, in the past, Utah has participated in the ADAM network in the year 2002, 2008, but in a much smaller surveillance area, 2010, and then 2012. And in prior study years, we tended to be have higher prevalence estimates than other sites. And there's a number of factors that actually drive some of our prevalence estimates. These include the demographic makeup of surveillance area, the urbanicity of different surveillance areas, community awareness of autism, diagnostic practices within surveillance areas, and as I mentioned earlier, the participating sites in the ADAM network change from year to year, and so do these underlying factors that are related to autism prevalence. So we think that in Utah, among our 8-year-olds, that actually our community has been very good at identifying children with autism and getting them to services related to autism. And so what we've seen is, we think, a number of other sites that are actually in some ways catching up with Utah a fair bit. As I mentioned earlier, in this study year, we are actually not statistically different than the estimate across all ADAM network sites, and we're actually not statistically different from many of the other the prevalence estimates in other participating sites as well, even among those that have higher prevalence, with the exception of California, which has the highest prevalence of any participating ADAM network site. So we think for 8-year-old children, we don't quite know exactly what the specific drivers are for the differences that we see in autism prevalence across sites, but we do know that each site is pretty different. So finding this kind of geographical variation is not surprising.
I do think there's something we can learn, though, from the differences we see across our sites. California is new to our network. Their rate was, I believe, 1 in 26. 1 in 26. We had 1 in 46. The ADAM network average was 1 in 44. So almost twice the increase that was measured in California. And there are aspects of the care in California that might be important for us to understand better in regards to how it may impact the identification of these children, particularly at a young age. Subsequently, their access to treatment so that they can really optimize their ability to learn and to engage with others and to develop independence. California has developmental centers across the state. The area in which the ADAM network did their surveillance in California has a very active primary care pediatric presence in regards to screening activities and referral activities for children with autism. And California does have a public preschool program that really facilitates children, particularly across the economic spectrum, to be able to have education in those preschool years. And when kids have that opportunity to spend time with other kids their age, it can become more apparent earlier on when there are some discrepancies in their abilities.
Thank you both. The next question that we have is about the differences between boys and girls and why boys are more likely to be identified with autism spectrum disorder than girls. So I don't know who wants to answer that one. It says, why are boys 3.6 times more likely to be identified with autism spectrum disorder than girls?
This is a ratio that has been consistent over time, pretty much since this ADAM network was established in the year 2000. While the exact 3.x to 1 ratio may vary a little bit, it has been very, very consistent, about a 4-to-1 ratio of males to females. There's a lot of hypotheses that have been proposed in terms of why we see this difference, and there is a lot of active work being done to address these hypotheses, some that we are doing here locally using ADAM network data. We are considering some of the, for example, we're considering some of the assessments that are used to identify autism and seeing if there's a difference in how males and females with autism score on these assessments. This is work that's being led by our colleague John Davis in the Department of Educational Psychology here at the University of Utah. There are other hypotheses that concern that perhaps that females may be better at a younger age at masking their autism behaviors, and therefore they're less likely to be picked up with autism even if that autism is present. That's another hypothesis that's being examined. There's other hypotheses that suggest that females need more autism symptoms as well as need co-occurring intellectual disability in order to be identified with autism. Right now we don't know definitively which of these hypotheses might be driving these differences, or if there's actual underlying biological reasons for these differences in male to female, in the male to female autism ratio. And I know Dr. Biller, you can probably can add to this as well.
So just to restate, it's unclear whether this involves a difference in risk, and so boys are at higher risk physiologically somehow to develop autism, or whether this is a measurement error, essentially, whether that relates to cultural differences, measurement differences from the perspective of the tools that are used, the manner in which girls manifest autism we know can be different, at least in some ways, than the boys, and so it's not clear exactly where this is coming from. I suspect it's coming from an aspect of both. My particular interest is understanding the prenatal etiologic factors which may contribute to a child's risk for developing autism and other developmental disabilities. And so this is something that our site, the Utah site, has really taken on among the ADAM network looking at prenatal risk factors, and not just how things may be related to autism, but whether there may be differences between males and females. And so our site in Utah, through John Davis's work, is looking at the social issues, the measurement issues, the clinical issues that could differentiate the likelihood a girl would be diagnosed with autism who has autism compared to a boy. And we also have work right now going on looking at, well, there are physiologic differences, perhaps during pregnancy or even maybe very early childhood, that may cause a higher risk among boys for developing autism than girls. So stay tuned.
We have time for one more question, and so I think we'll end with this question. What can parents do to ensure that their children get properly evaluated? And the second part of that question is, what resources do you recommend for families of children with profound behaviors?
Right. So I will address the first part, and Dr. Bilder has a lot to say about the second part as well, and both pieces. But I'd first say, so there are a number of programs and resources out there for parents to access. Some of them come from the CDC. First is a program called Learn the Signs, Act Early. So if a parent has any developmental, any concerns about their child's development, they can go to the CDC's website and take a look at the Learn the Signs, Act Early. And we have even Utah-specific resources along those lines. That's one place to start. Of course, they should speak to their primary provider about their concerns with their child. The Utah Department of Health, and Colin, who spoke earlier, maintains an active website with information for parents who maybe have concerns about their child's development. There are a number of different early intervention programs for our younger children aged 0 to 3 years of age, and then as well as above 3 years of age. So there are a number of resources available to parents to consider if they have developmental concerns.
As far as behaviors, children and adults with autism are certainly at higher risk for having significantly disruptive behavior. And the disruptive behavior these individuals experience affect substantially their ability to be in the community and be around others and have an opportunity to learn with the other kids in school or work on a job site. So disruptive behaviors is a substantial issue that definitely seems to be associated, at least in part, with autism spectrum disorder. As far as how to address these issues, because they can be disrupt entire family, entire situation, there are great resources in our community. And one of the first groups I recommend reaching out to is the Department of Health. Colin Kingsbury maintains with his team, including Eric Christensen, maintains a list of resources and referral suggestions, including understandings even in regards to what insurance someone has or where they live, to try to help match them up best to the resources in their community to help their child access services to improve their behavior choices, improve their ability to communicate their needs and wants without terribly disruptive behavior, their ability to make better choices, which ultimately will get them their needs met, as opposed to the disruptive behavior, which may work in the short term, but long term is really not a solution for them or those around them.
Well, Colin, since both Dr. Bacon and Dr. Bilder referenced your resources, do you want to talk a little bit more about them, or maybe put the web address in the chat for us so that we can access those easily?
Yeah, and if I can just swing back to the questions for what parents can do, I like to make it really simple for them. All children should be screened for autism at 18 and 24 months using a screener called the MCHAT RF. Help Me Grow Utah offers this service for free. So parents can call Help Me Grow Utah, get that screening done. It comes right to your phone. You can do half of it. It's like 20 questions. The parent has time to do 10 questions today and 10 questions tomorrow. That's no problem. They can do that. Also, finding an evaluation can be very difficult. So for parents, this evaluator doesn't take my insurance, or this one has an 8-month wait list. Like they mentioned, we maintain a list with all of that information on there. If parents need help finding a provider, they are welcome to call me at any time, and I am happy to walk them through that and find a provider that works for them.
Thanks, Colin, and thank you everybody for joining us this morning. If you have questions, we didn't get to a couple of questions, but feel free to follow up with me. I can pass your questions on to our experts today, and we can be sure to get your questions answered. Thank you again for joining us, and thank you to our experts, Dr. Builder, Dr. Bakian, and Colin Kingsbury, and have a wonderful rest of your day.